the analogy that Emily touched on, that the Pacific can be a leader in digital health, is not just a line that we roll out. If you look at M-Supply, it was developed in a warehouse in Nepal, but the first country that it was implemented in overseas was Tonga. Now, M-Supply is the most widely used LMIS for health supply chains in low and middle income countries in the world. It's used in over 40 countries in the world now. Every single day, hundreds and hundreds and hundreds of thousands of transactions go through an M-Supply system somewhere across 4 continents around the world. It started in Tonga, and a lot of lessons from Tonga have been applied to those implementations around the world. I'm not sure if it's the exact second, but certainly close to the second was Solomon Islands. These are tools that were grown in the Pacific and have expanded out into the world. But it's not just the line that we roll out. The Pacific really can be a leader in those areas. And as Emily has also touched on, there's the opportunity these days to leapfrog some of the higher resource settings around the world who are, to be completely honest, laboured by legacy software that can actually hold them back, and legacy programs and far more complex health governance and politics that can hold them back. But with all of that said, I did want to get into something that maybe would prompt some more discussion, start to loosen up some of the formality of the meeting and talk at a more informal level about, well, why do digital health projects fail? And maybe use some of those lessons to explore why digital health projects can succeed. Maybe some controversial things in here, but hopefully, as I say, it starts to prompt some discussion and the sort of more informal conversations that we want to encourage on the side. So let's start with it. So they say, and then it depends on what source you look up for these things. There's a lot of sources, but generally speaking, sources agree that about 70 to 80% of digital health projects will fail. That makes people think that digital health is a really risky investment. But 70 to 80% of digital health projects government-wide will fail. This is not a digital health project. This is not a digital health problem. This is a digital problem. Digital health projects are risky, they're complex, they're expensive, and they fall over quite a lot. I don't think that it's something that health needs to beat itself over the head about and say, oh, there's something intrinsic to health that makes digital projects difficult to succeed. In fact, I think we just spend a lot of time, beating ourselves up over issues that are quite universal and seen across all government programs. I don't know what the figures are from the private sector, but I suspect they're probably similar as well about digital projects that fail. But I guess you could also say, well, if digital projects are so risky and expensive, why invest in them? And that's because all projects are risky. The majority of public health programs in low resource settings will fail. Every single person in this room who's worked for any more than a few years in this area can think, I know you can, of a project 5 years ago, 10 years ago that is dead in the water, right? All of us, we've all been involved in projects, even recently, where the project is no longer running, the data is no longer available, the project never delivered benefits or outcomes to anyone. Nothing to do with digital, it's just public health program in these settings can be very, very difficult to gain traction with and sustain and maintain and actually deliver results. So we look at ourselves and we say, well, this is a really difficult area. This is a really difficult area to invest in. But remember also that the majority of public health programs in high income settings fail as well. For those that have worked in countries like Australia or the US, they will also know that we can look back at projects 5 years ago, 10 years ago. All of us have experiences with projects that are dead in the water, where the data is no longer available, the project never delivered success. Again, this is not an area that we should just beat ourselves up over constantly. Investment is risky. Investment in public health is risky, and none of these should be reasons that we don't continue to invest in them and invest in ourselves, because when they work, they can be transformative and they can really change lives. But it is useful to explore some of the common reasons for failure and try to use them as lessons for success in the future. That is a difficult topic. I don't know how many of you read Tolstoy. I certainly don't. This is the only quote that I know. But when we look at successful public health programs or successful digital health programs, they all basically succeed for the same reason. Everyone got everything right on that program. The projects that fail all fail for their own reason. If you go back and examine each of the public health programs or the digital health programs that have failed, there's always one thing that you can point to that was unique to that project that caused it to fall over. So it's a difficult topic to speak on. We could stay up here all day and run through hundreds of small projects and point to these deep analyses of why they fail. But hopefully I've today managed to pull out a few of the things, a few of the common threads that we can look at and use them as lessons for planning in the future, not just with our stuff, but with any project that you're implementing about what can make it work and not. And before we get into that, we just also want to ask the question of what is failure, okay? Because failure can mean different things. It can mean total failure. So the system's simply not used at all. You return to a project 2 years after implementation and it is gone. It's not being used. Obviously, that is a project failure. But project failure can mean different things in different contexts. So you may be having a digital health system that has great user uptake. It's used every single day, but it's not actually being used to drive change. It's not being used to improve outcomes. That data is not used for decision making. It's just a data collection tool that runs in the background. And I'm sure we can all think of those ourselves where you are collecting data for the sake of collecting data, but no one's actually doing anything with it. Budget overruns. A project can be deemed to fail if you end up spending 3 times the budget and you've pulled funding away from other areas that are just as worthy. Digital health projects are not effective if that cost benefit falls away as well. The data is wrong, it's bad, it's unhelpful, it's untrue, it's misleading. Digital health projects that seem successful can be counterproductive if, when you actually dig into the data, you realise that it is telling you a story that is not true. That is also an example of failure. Usage does not mean success. Obviously, we have extreme examples of data leaks, privacy breaches, hacks, and these sorts of things. And increasingly, we need to be aware of these because the Pacific is also now subject to targeted and state-sponsored attacks on their critical IT infrastructure. Those attacks haven't necessarily focused too much on health in the past, but I promise you they will. This is not a benign sort of generic thing. These are targeted attacks on state infrastructure, as well as, of course, well-meaning users who accidentally leak data through poor usage. And you can't see the bottom one there, but suboptimal use, where a project seems to be working well, but could be far more effective. You could deem that to be a failure as well if you're not getting the full return on your investment that you wanted. But with all of that in mind, let's look at some of the reasons that projects fail. We talk about this a lot. It's probably my favorite quote within BES. Perfection is the enemy of good. What do we mean by that? Well, we mean 2 things. And this is where I'm going to start to get controversial and hopefully spark some of the conversations. The idea that a nurse working in a primary healthcare facility in the Pacific is going to use a different app for the immunisation program, an NCD screening project, their cervical cancer screening, the school screening. They pick up a different app to do a particular communicable disease program. Then they've got their normal health record app. Nurses, frontline health workers in the Pacific simply wear too many hats for that to be feasible. And the idea that nurses or clinicians out in those settings are going to grab different apps and go to all these different programs for all of their different needs, to us, is pie in the sky stuff. None of those individual highly specific projects is going to be sustainable. Now, that doesn't mean there's a one-size-fits-all thing, and obviously there's a bias here because we talk about our own systems being integrated. We're not simply talking about our own things. It's not feasible that one software can rule them all. There are different use cases within a primary healthcare setting. But if you are implementing a new digital health project, perfection is the enemy of good. You may list out 100 requirements of what your software needs to achieve for your program. And if you can find an existing software that meets 90% of them or 85% of them, use that software. Trying to achieve perfection, which almost inevitably means you need to introduce an incredibly specific app or an incredibly specific tool to meet that need, sets you up for long-term failure. It's expensive. It's not the IT teams to support it. Perfection becomes the enemy of good. If you look at the number of tools on the market these days, there's thousands, us included. you can't possibly be expected to find the exact perfect app to meet your program needs. And at the end of the day, people need to compromise. And that means we need to compromise. We need to look at what is the minimum data set that we require versus what is the perfect data set that we require. The other part of perfection being the enemy of good is an idea that gets used in tech quite a lot called fail fast. Now, we realise this term scares people, so we don't call it fail fast, we call find out fast. We have seen projects where the leaders of the project are so obsessed with getting it absolutely perfect before they go live with the system with real-time users that they end up burning all of the money, all of their time, and all of the momentum that starts behind the project before they actually get it out into the field. When they get that out into the field, you have just as much chance of finding out that there was a fundamental flaw with your planning as you did if you went live with it 6 months. Now, we don't mean you rush systems and you rush projects out into the field within 2 or 3 weeks. But what we mean is don't spend 18 months trying to predict every possible thing that could go wrong, because we guarantee something will go wrong. But you need to find that out fast so that you can fix it, so that you can iterate, and so that you can maintain momentum as you scale the project up. Finding out fast is not a bad thing. Having early problems with a project that you're implementing doesn't mean that the project has failed. But I'll talk about that a little bit later on. Wide anting. So what do we mean by wide anting? I was showing this presentation to someone last night who had never heard of wide ants. So we might call them termites or undermining. There is a very fine line between the constructive criticism and the review of projects that is really useful. Projects should be examined, they should be probed. You need to look into projects and make sure that they're working, that they're fit for purpose, that there's transparency and all those sorts of things. But there's a difference between that and white anting. White anting is that person on the project who is constantly chipping it and criticising it and maybe publicly presenting a great face, but at every single meeting is chipping away at the project, undermining confidence with every single person that they speak to. Those people are a cancer to the project and they will kill it. And we've seen it with our projects and everyone here has seen it with their projects. I can tell from the reaction. So you've got to look out for those white ants and you've got to make sure that you are addressing them head on. As I say, the counterbalance to that is that sometimes a project is not worth funding. A project really is terminal and it should be it should be defunded. But you don't do that through white anting. Don't do that through this constant little undermining and criticism and looking for problems. That needs to be done in a transparent review way where someone who is completely neutral to the project is not just looking for problems, they're looking for successes as well. And we see this, as much as I'm sure all of you said, that when people are brought into review programs, people that look only for the negatives can undermine a project as well. They think they're doing a good thing, but we feel like all reviews should be looking for both the positives and the negatives. And unfortunately, some projects fall over because people lean too far to one side. I want to give a counter example of this. I can see Jeremiah up the back there. One of the reasons that the Fiji National Health Supply Chain Reform Project, in our opinion, has worked so well is that we haven't seen this. Everybody from the ministerial level down through the permanent secretary and down through the leadership of pharmacy has been on board endorsing it with 360-degree support, including the program support facility. Now, that doesn't mean that the project has been unexamined. In fact, it's been looked at, it's been reviewed, and will continue to be so, and it should be. But that's not white anting. That's just reviewing and making sure that the project stays on track and that we pivot it and change it as much as we need to. But if you have that 360-degree endorsement where everyone agrees this is what we're doing, the end users sense that, they feel that, and it translates into good use. And that's a really good counter example of a project that's working well because we don't see this issue. The first hurdle. What do I mean by the first hurdle? The first hurdle is when an end user has a system, they've left the training room, they are in a live environment with a patient in front of them, and they hit that first problem. Now, these are just some that sort of off the top of my head. They've forgotten their password. Windows needs to run an update, or the the Android device, iOS, needs to run an update. They've got the wrong software version that someone's accidentally installed in the rush to get it out the door. There's inconsistency from what they can see on the screen from the training version to the live version. Just one field is different and it's confusing. It's called something different. That's not what they were trained in. There's a small software bug, so it just throws an error up at their screen. It happens with all digital health projects. There's data entry form errors. Something in the data entry form is wrong. The workflow just takes too long, and when it's actually applied in the clinical environment is not fit for purpose. Or there's a knowledge gap. There was something that they were not trained in. But I'm sure there's other things. You can all think of that first hurdle, the first time you were in front of a software and you had a problem and you're like, I got a patient with me right now. I need to get this patient treated. I need to get this patient examined. I need to get them out the door. I'm just going to use the old system, whatever that is, and we'll come back to this. Once the staff member does that, they will never come back to the new system. You have, in almost all cases, lost them. So when they hit that first hurdle, and they will, you need to be able to support them. That might be an at-the-elbow support or a very, very clear communication channel of how they get support and how that support gets to them very, very quickly, so that they can feel supported and they can feel confident that the next hurdle that they reach, they're going to be able to overcome it really quickly. And I want to give you an example of a project that we were involved with where this was the problem. We implemented a COVID-19 testing program up in Kiribati using Tamanu. This was not the fault of Kiribati. I want to make that absolutely clear because I know that people from that program are in the room. This was our fault. We didn't resource it properly. It got out the door too quickly and we were not able to give users that support. Was it a software problem? Well, Fiji was using the same software and they did about 300,000 tests using the exact same workflow. Kiribati did about 3,000, 4,000 tests using the system, but one by one, users started to hit hurdles. One by one, they started to hit things that went wrong and we were not able to give them support. We were not able to help them overcome that hurdle before they needed to get to the next patient and move on. And one by one, we just started to lose users from that system, and that was on us. Now, hopefully we can take those lessons and apply them elsewhere. But as I say, we don't want to make this too specific to us. We want to make this general to any program that you're implementing. You need to make users feel supported in those early days of the project. 6 months down the track, when they come up to their 10th hurdle, hopefully then they feel a little bit more confident that they know the workaround, they know the support channel that they need to access, this sort of thing, and they can move on. But that first hurdle, that's the key. That's when you lose people. Resourcing. This is an obvious one to say, but we wanted to present to you just how much goes into digital health programs. When people think about digital health, I think probably they think of hardware, project manager, IT support officers. Get those things out there and you've got your digital health project all lined up in front of you. It's very, very difficult to understand without knowing the technical elements that lie behind all of these. But what is going on behind the scenes, not necessarily visible to the end users or visible in country, is massive. What needs to go into major digital health projects now is massive. A data team. At BES alone, we have a 4-person full-time data team that work away in the background, heads down, looking at data sets all day to support the programming around the region. DevOps, you might not know what DevOps is, but think of it as what keeps all of your systems running on a software, hardware, network architecture level. DevOps is what allows you to scale, it's what allows you to be stable and all that sort of stuff. If your DevOps is working well, you will not be aware of it. If your DevOps doesn't work, I promise you, you will be aware of it. That's when systems start to fail really catastrophically. Your remote support desk, your solutions architect who might be designing all of your integrations, BA, or what you might call the step that comes after requirements gathering. So mapping, for example, workflows to software workflows, to reporting requirements, to data requirements. That's your BA. Your software development, and then these days, massive levels of risk and compliance that go on with digital health projects. To make sure that patients are protected, to make sure that policies are in place, to make sure that your staff have child protection procedures in place. These are the sorts of things that go on behind digital health projects that are extremely expensive, and it's why a lot of them end up costing a lot of money and taking far more time than people think. The resourcing is a lot. But the other thing is that people tend only to think of the go live, or that sort of wonderful 4-6 week period when there's a lot of staff around, you're going live, systems are being turned on. We love it. I know anyone involved with digital health projects loves it. That's the exciting time. But the build up to that, the project steps that get you to there, and the project steps that follow that also need to be invested in. And if you don't invest in them, the project will fail. The go live is important. The go live is that critical moment when the systems turn on and people need to use it. But if you haven't done all of that planning and you don't do all of that follow-up support, the project will fail anyway. So resourcing is a huge thing. Impatience. There is something about digital health projects that makes people extremely impatient for results, and we don't know what it is. But we anecdotally see this quite a lot. Either when a project kicks off and you get 3 months down the track and people are asking you why has this project not gone live? Why is the software still not working? No one's been trained yet. What's going on? Or as soon as the system does go live, people start asking you, how many lives have you saved? What are the final outcomes? How have you transformed across these 11 different indicators that we need you to report on? Never, never DFAT. But occasionally it has been seen from other people. And what you then get is the blame game. Now, I think there is more patience around other public health programming, and particularly with clinical programming, where people appreciate that these things take a long time to embed and they take a long time to see results from. But there just seems to be something about digital health where people get impatient. And again, I want to give a counter example and a call out to the Nauru Ministry of Health. We were recently taking a very long time with the hospital go live in Nauru, and called for patience from the Ministry of Health and from the donors there, just to give the program time enough to make sure that all that planning was being done right. Now, we could have done the opposite. We could have rushed it out the door. We could have gone 3 or 4 months early, and I think it would have really shot ourselves in the foot. The Ministry of Health and the donors gave us the patience that we needed to make sure that that program was properly formed, properly planned, properly delivered, and early days, but the go live, which was done in June, has been a real success, and the uptake from users has been really good. Now, again, obviously, I'm completely biased on this particular example, but I did want to sing out to the people from Nauru in the room to say that is what made the difference. It wasn't that we did the planning any different. It wasn't that we changed anything fundamentally. It's just that some key people showed patience at key moments, and that made all the difference. Now, that's not to say that you give people as much rope as they ask for, and obviously there are timeframes and there are budgets that are finite, but making sure that you're patient with your own programs can help to ensure that all of those steps happen, and making sure that you understand what those steps are will make you feel more comfortable that money's not being thrown away and investment is not being thrown away. I don't even need to say this one, but government IT human resources are not keeping pace with the scale of digital transformation that's expected across the region. We see this obviously in many countries. This is not just a problem confined to health, but because the expectation around scale up of digital tools in health is so large at the moment, I think a lot of the spotlight falls onto health. And the local IT support is not being scaled at the same pace that the software is being scaled. And it's not just numbers, as we were talking about earlier just this morning. It's not just the number of staff that you have, it's a skills gap as well. There are some countries in the region, and particularly some governments in the region, where there is still a perception of IT support being the one person that works at a hospital who goes around turning computers on and off, making sure the network cables haven't been eaten by rats, and installing antivirus software. In a modern sense, that is no longer sufficient to provide IT support to a national program, health or otherwise. These days, most IT support, you need really advanced understanding of, for example, network architecture, data stewardship, cloud services in a lot of cases, DevOps, basic software development and some of the steps that go into customizations of tools that you're using, product ownership at a local level. All these sorts of things, the IT team within your ministries of health and within your governments need to be able to support. And of course, those skills haven't necessarily been met in all countries by the local IT teams. They need to be upskilled. And once you upskill them, you need to pay them more. Because what we see in a lot of countries is that the highest skilled IT support, network architecture support staff are not being paid market rates. And what I mean by market is those staff are extremely valuable on the private market. They're extremely valuable to other government ministries. Ministries of health need to pay them more. You need to think of them like you think of your surgeons and your top consultants, because that level of skill is getting to the point where it's quite comparable. Now, I'm not necessarily saying that you need to pay them the exact same as some of your top clinicians, but those are the sorts of pay scales that you need to be starting to think about. The skills are worth it, and that's what the market is paying, and we'll continue to see really, really terrific IT staff disappearing out into the markets, including overseas, unless they are compensated at a fairer level for some of the skills that they're developing. Bringing end users into planning. This is a huge one. We are often implementing programs where everything has been planned meticulously. We're implementing a very, very set program of work where all of the software requirements and network requirements were laid out well in advance. We go to implement it, and as soon as you get it in front of an end user, you realise that it doesn't actually match the workflows down at the clinical level or at the public health level, and the program is therefore not fit for purpose. Bringing end users into planning as early as you possibly can, and we mean local, actual clinician or public health end users who will be using the system as early as you possibly can, is really, really important. Hopefully it goes without saying, but I want to give you an example of a project that didn't do this, but used the lesson. My PhD, we implemented M-Supply Mobile at 6 facilities across Solomon Islands. It's the first country in the world that did it. And Cosmos is in the room, actually, who was involved with that. He'll remember. There you are. The problem with it was you needed to be online to use it. And we'd never really tested that in the field in Solomon Islands. So we worked with M-Supply, we worked with the Ministry of Health, we got it out into the field, and it didn't work. No one's ever actually read any of the research from my PhD, but if you did read it, what you would realise is that it didn't work. But we were able to identify why it didn't work. And it was only after finally getting down and actually experiencing that with end users, as I say, not just me, but a whole group of people getting down into those second-level medical stores and realising why that didn't work, and realising actually this was a greater burden on them than the old paper-based systems, that by the time M-Supply took M-Supply Mobile to East Timor, there they had a system that could work offline, and there they were able to bring in software developers into Timor and work with end users to tweak the final end product to scale it up. Also possibly because that had less to do with me, but let's not get into that too much. Today, M-Supply Mobile is used in 300 facilities in East Timor. It's used in thousands of facilities around the world. It's a great software, but it didn't become a great software until it was actually drawing lessons from end users, and not just a software project being developed out of Auckland. With no offence to some of the people in the room who were involved in that. It's an example of learning from failure. And I think it's a good one to take, because failure doesn't have to be the last failure. You can lose a battle without losing the war. And I think in that case, as soon as I stepped away from it, that project became really, really successful. I wanted to finish with this quote, though, because we have seen it with our own tools, and I'm sure you've all seen it. And I think it's something to remember as a mantra, that every single digital health project that does not provide benefit or to or utility to the people that have to enter the data will fail. If you are implementing a digital health project that will help planners at the Ministry of Health, that are going to help, the most senior level people produce their reports for the donors, and it's going to automate all of that reporting process, and you just get this absolutely easy one-click report at the end of it that will solve all of your problems, but you are making life more difficult for the end users at the clinic that need to enter the data, it will fail. they will do you a favour for a while. They will be engaged for a while, but we all need to make sure that the projects that we're implementing help those people make their lives easier, make their workflows faster, provide utility to them rather than just asking them to do it because that's their job. Then they will work. And if we always start with that as our first point of reference and think about the benefit to us and to the senior level users as a secondary consideration, then we have a chance to succeed with digital health projects. And as I say, learn from some of the failures in the past. I hope you all enjoy the forum over the next few days, and I hope you're all able to have as many conversations with each other as you possibly can. As I say, we're absolutely proud and wrapped and just really enthused about you all being here. And we hope that you feel that as much as anything from being with each other. Obviously, we're getting to a little bit past COVID, but I'm still seeing so many people in the room that I've only met on Zoom or only met on email. And it's just an absolute pleasure to see you all in person. So hopefully the forum provides an opportunity for you all to talk to each other, share lessons, and hopefully, as I say, improve the planning for projects that come in the future. Thanks.